Hello, my name is Karen Kuberberg and I'm a dietitian at Sick Kids. I am involved in a program run jointly between Sick Kids and Toronto Central CCAC in which I do pediatric home visits in the Toronto area. I'm here today to talk to you about managing pediatric tube feeding in the community. So by the end of my presentation today, you will feel more comfortable in assessing the current tube feeding plan and identifying factors of intolerance, and you'll feel more comfortable in making changes to the current tube feeding plan to help achieve tolerance. I have no conflicts of interest to disclose. Let's begin today by quickly reviewing a few basics of enteral feeding, starting with routes of administering enteral nutrition. The three routes of administration are number 1, oral, number 2, gastric feeds, either NG or G-tube, and number 3, transpyloric, which is either GJ or gastrojejunostomy, G or surgically inserted J-tubes. Now we will review the different types of pediatric enteral formulas that are available. Generally, pediatric formulas fall into 3 categories: polymeric, semi-elemental, or elemental. Polymeric formulas can be given either orally or by feeding tube, while semi-elemental and elemental are generally given by a feeding tube. There are also blenderized formulas, such as complete, which is generally tube-fed. Modules contain one or more macronutrients, including fat, protein, or carbohydrates, and can be added to a pediatric formula to boost calories or supplement a specific macronutrient. Let's now talk about when children are discharged from hospital. They go home with goals set by the medical team. And once they get home, although the goals of the medical team are still very important, the goals from parents also come into play. The parental goals are often not top of mind while the child is an inpatient, as parents are never fully responsible for the care of their child while in hospital. There is also a formula room which prepares and delivers the formula, and there's 24-hour nursing care which assists in administrating the feeds and assessing the child. Once a child is home, it is very important to understand that parents are able to handle. Also, changes they may make to a child's feeding plan could have significant impacts on the child's ability to tolerate their feeds. While at home, the main markers of tolerance to a feeding plan I use to assess are the child's growth, signs of nausea or vomiting, their stool frequency or consistency, and fluid status. Once a child is tolerating their feeds and they are growing and feeling good, feeding plans are then adjusted to ensure they are meeting optimal nutrient intake. Blood work is done infrequently in the community. However, changes to feeding plans are made immediately based on abnormal blood work results. Although the incidence is very low, children may not tolerate formula due to cow's milk protein allergy, generally identified in infancy, at which point they are put on a dairy-free formula. Other causes of intolerance could be lactose intolerance, which is very rare, or fat malabsorption. As you can see here, more often symptoms of intolerance are vomiting or reflux, chronic diarrhea or constipation, failure to thrive, anemia, irritability, or GI bleeds. Of these, I would say that most often I see vomiting or reflux, diarrhea or constipation, failure to thrive or slow or minimal growth, and irritability as the symptoms of intolerance. So, why is intolerance so important? We know that when children are the ones who are unwell, it affects the entire family. Parents want to be able to include the child in all aspects of family life and have the child spend quality time with the family, whether it's going to the park, day trips as a family, or letting the child play with their siblings. When the child is unwell or not tolerating their feeds, it makes it very difficult. Intolerance may mean a child is connected to their tube feeding longer than necessary, which can interfere with having fun and feeling normal. It can also impact the child's ability to go to school, which is a major part of any child's life. It is important to develop a tube feeding schedule which a child can tolerate and which fits with school. Lastly, comfort is probably the most important factor to consider. If the child is not comfortable or tolerating their feeds, then none of the other factors can be achieved. A child will not want to spend time or be able to spend quality time with their family. They will not be able to go to school, and they will not be growing adequately, and they will not be having fun or feeling normal. When a child is not tolerating their feeding plan, there are several factors to consider. As you can see here in this diagram, the factors and causes of intolerance may be GI-related, environmental, or formula-related, and they are as follows. Starting with upper GI, one thing to consider is formula, as the type and characteristics may have an impact on the upper GI tract, such as gastric emptying time. Also, observe the child if they have reflux or nausea and or vomiting, as these may be signs of needing a change in formula or feeding rate. Moving to lower GI, either constipation or diarrhea may be signs of intolerance. Note medications that the child is receiving, as they may be a factor. Adjusting or initiating bowel medications may be necessary to alleviate these symptoms. Also linked to GI is tube placement. You may want to verify that the enteral tube feeding plan is in the right place. When a GJ tube has been accidentally displaced by being pulled into the stomach, children are unlikely to tolerate their feeds. Signs of this may be increased reflux or vomiting, often vomiting formula. Similarly, if there is a GI obstruction, you may observe reflux, vomiting, or watery diarrhea. Under environmental, there are two separate considerations: medication and formula handling. When looking at medications, timing or dosing may be important. If a child has chronic diarrhea, check the sorbitol content of the medication, as higher levels of sorbitol may also increase diarrhea, and there may be a sorbitol-free alternative that can be used. Also, medications for symptoms like reflux may be needed to be adjusted. An often overlooked factor is the handling and the preparation of formula. It is very important to look at how formula is being prepared, especially if families have been asked to dilute or concentrate feeds. If recipes are not followed exactly, formula may be more concentrated or more diluted than intended, and this can lead to symptoms of intolerance. In addition, formula needs to be handled properly in terms of hang time and safe preparation to avoid contamination. In my setting, recommended hang time for formula should not exceed 4 hours, and the cleaning of the tubing and feeding bags adequately is encouraged. Formula itself may be the final consideration, as it is a role in all other factors we've just reviewed. Changing the formula or reducing the rate may be a way to overcome intolerance. Taking all the above into consideration, when a child does not tolerate their feeding plan, one approach to management is the following. The first thing to consider is slowing down the rate of feeds, moving towards continuous or extending length of continuous feeds. Simultaneously, I would contact the pediatrician or hospital team involved to maximize any reflux medications. I would ask about constipation. I would consider using prune juice, changing to a formula with fiber, adding extra water flushes, or suggest giving or increasing medications for constipation. The second thing to consider is possibly diluting the formula, especially when transitioning from infant to pediatric formulas, as pediatric formulas have a higher caloric density. Finally, I would consider changing the formula, moving from a polymeric to a semi-elemental to elemental. Of course, this is only done after consulting with the pediatrician or hospital team. Regardless what I would do, I would never make more than one change at a time. To help clarify my approach, I will review a little girl that I've been following in the community since birth. This little girl was born with trisomy 18, and I've been following her for the past 2 years. She's been struggling with reflux and with failure to thrive ever since she was born. She recently had a G-tube inserted due to recurring aspiration pneumonia. Prior to G-tube insertion, she was eating purees and drinking infant formula from a bottle. When she was discharged from hospital with her G-tube, she was put on a bolus feeding schedule of 200 mils per feed at a rate of 50 mils per hour. However, as you can see, this was not exactly a bolus schedule, as she was running almost continuously, but it was a start. We would work on making it a true bolus schedule with a goal rate of 150 mils per hour. At my first home visit, which was 4 days post-discharge, the parents had already increased the rate of feeds to 80 mils per hour to move closer to the goal of the feeding plan. The child was irritable and vomiting throughout the day. She had also lost 200 grams, which was notable. My plan at this visit was to decrease the rate of feeds back to 50 mils an hour. I explained to parents the importance of not changing the feeding rate, and I scheduled my next visit in 1 week. At my second visit, there was little change. Feeds were running at 50 mils per hour, and the child remained irritable and continued to vomit. My plan now was to decrease the feeding rate to 45 mils per hour and run continuously over 22 hours. I also contacted the hospital team to ensure her reflex meds were optimized. I explained to the parents that continuous feeds would hopefully only be temporary and that we would continue to work towards the goal of 150 mils per hour. At my third visit, the little girl was still not tolerating her formula, so I decided to decrease the concentration of the formula to 0.67 calories per mil, as this was the concentration of the infant formula she was drinking prior to G-tube insertion. I came back a week later, and again she was not tolerating her feeds. Having already tried decreasing the rate of feeds, ensuring reflex meds were optimized, and diluting concentration of formula, my next step was to recommend changing the formula to a semi-elemental formula. My plan was to dilute this formula to 0.67 calories per mil and to give it as a continuous feed of 45 mils per hour so that as many variables remained constant as possible. Once tolerating this new formula, I would work up the rate and then the concentration slowly. Although it took 4 months, by making changes slowly, we reached the goal of 150 mils per hour as bolus feeding. More importantly, the parents were comfortable managing the tube feeds. The girl was growing, gaining weight, and making developmental gains. The little girl was able to go out to the park and for walks without being hooked up to the feeding tube, and her parents were looking into a preschool. As indicated from my objectives, now that my presentation is complete, I am hoping that you will feel more comfortable in assessing the tube feeding plan and identify areas of intolerance, and feel more comfortable in managing the current tube feeding plan and make changes if there are any issues with intolerance. Thank you for your attention.